This video lecture is on enteral nutrition, parenteral nutrition, and barriers to adequate nutrition. Enteral nutrition. This is where we use the GI tract. So when you and I eat food, that is enteral nutrition. In healthcare, when we say someone's on enteral nutrition, what we're really saying is we're using some sort of formula feeding, so some sort of tube feeding. We prefer enteral nutrition over parenteral nutrition when the GI tract is functional, because that's going to keep that GI tract alive and healthy. It's a muscle like anything else, and it can atrophy. So we want to keep it working whenever possible. Reasons why we might put somebody on enteral nutrition is because they're not consuming enough through their oral intake. They have severe dysphagia or difficulty swallowing, had oral injury like the jaw wired shut, they're intubated, they're unconscious, or have major burns, are just some of the reasons. There are lots of different kinds of tube feeding or formula feedings out there. They have different calorie concentrations, between 1 and 2 calories usually. 2 calorie, we also kind of call that fluid restricted, because the more calories per the per ounce, the less or per cc, the less fluid that's going to be available in there. There's also disease specific formulas like renal formula, low or high fiber formula, diabetic tube feeding. In the hospital, it's the dietitian who's going to determine caloric needs and make recommendations of rate and when water flush needs to the provider or the physician. So, for example, this picture up here is actually showing you, saying, based on the patient's needs and the formula being used, it's telling you this is how much free water they need to be getting, and this is how much protein they're getting, and all that kind of stuff. That is really above and beyond what the nurse in the hospital would do. That's really more of a dietitian, but you are responsible for knowing the correct type of formula the patient is getting. Maybe, for example, suggesting if their potassium level is rising, maybe they need to be put on the renal formula. Also making sure that you're giving the water flushes and those kind of things. As you can see here, there's different types of tubes. So what you need to know is, where does the tube start and where does the tube end? The name itself is telling you. So when you say your patient has an NG tube, that stands for nasogastric. So nasal, it's starting in the nose, it's inserted in the nose, and gastric means it's ending in the stomach. Like this one right here is a naso, and then gastric stopping right here. An NJ tube is a nasojejunal, which means now it's in the small intestine. We can also have things called PEG, or J tube, or G tube. The PEG means percutaneous endoscopic gastrectomy, or something close to that, where it means that they used an endoscope to insert this tube into this person's abdominal wall. And the G means that it's ending in the stomach again, the gastric, where if it was a PEJ or a J tube, that's telling you that this tube right here goes into the stomach and goes into the small intestine, such as right here. Like here's a G tube, here is a J tube that goes down into the jejunum. That is all for enteral nutrition. For parenteral nutrition, TPN, total parenteral nutrition, you are required to use some sort of central line. Usually what we use is called a PICC, peripherally inserted central catheter. As you can see here, this is what one would look like. It's inserted peripherally, but this tubing, as you can see in this cartoon here, again, is inserted maybe in the basilic vein, but then the tube goes all the way through, and then it stops right here at the opening of the atria. So when you take this type of IV out, for example, it's like 18, 30 inches long, depending on where it is. You could also use any sort of central line. So they might have a central line like put in their chest, for example. A metaport would be a central line. And an IJ, which stands for internal jugular, which would be put in the neck here. Again, all these tubes are central lines because they go all the way, they stop right here in the heart. Whereas the IV you and I put in, a PIV or peripheral IV, those would not be acceptable to use TPN. In your ATI, it does talk about PPN. We are not going to cover that at all. I never see it used that way. TPN, total parenteral nutrition, through a central line, usually a PICC line, is what we're going to be talking about. All right, so let's discuss, how is a tube or route picked? First and foremost, we want to use the GI tract whenever possible. If it atrophies, or excuse me, it atrophies when it's not used. So if the GI tract is functional, we want to use it. Now, how long are we going to need to use the tube? Because if it is going to be usually 3 or 4 weeks or less, then we're going to want to insert that tube in through the nose into the jejunum or the gastric, so an NJ or an NG. If that's going to be for 4 or more weeks of feeding, then we want to do something like a PEG tube or a J tube or G tube. You can see here when we put it in when the tube ends in the duodenal or the jejunum, that's going to decrease risk for aspiration because that tube is all the way into the small intestine, so you can't aspirate up your small intestine, up through your stomach, up into your esophagus, and then into your lungs. So that's one great thing for that one is it decreases risk for aspiration. But a bad thing is you can't bolus feed through there. So that's going to be for continuous feeding. So now if your patient's going home, they need to be hooked up to that tube feeding all the time. They can't just give themselves some like 4 times a day. And then TPN use, we usually use that for someone who has some sort of GI trauma, pancreatitis, or an ileus. You can look on page 313 in your Grodner text. There's a table 14.6 that has the pros and the cons. You can see here, according to Grodner, we really only use TPN for somebody who can't get absorbed nutrients to the GI tract for more than 10 days. ATI says 7 days. I'm not going to be testing you one way or the other and make the answer, is the answer 6, 7, 8, or 12. That's too specific. But again, we don't use parental nutrition unless we have to, is really the point this slide is trying to make. All right, so first we're going to focus on enteral nutrition, which is some sort of tube feeding. So continuous. Continuous is going to be the preferred method. This means that the person is getting nutrition over 24 hours, the entire time. This is going to require some sort of feeding pump, like you can see a picture right here. Then we have what's called intermittent. Intermittent is where we give usually, a lot of times we give over 60 minutes. You can see on the slide here it says given over 30 to 90 minutes, and this is 4 to 6 times per day. What's really nice about intermittent tube feeding is now maybe I might give somewhere between like 4 to maybe 500 milliliters of tube feeding. And now the person doesn't need to be hooked up to a tube all day. So they can make it more like meal times. They can have one at breakfast, one at lunch, one at dinner, and one at bedtime. But they're not connected to a tube all the time. The other thing to think about though is you have to be careful about rate because rate causes more discomfort than total volume infused in patients. So sometimes what you need to do is you need to slow it down. It's good. When people start complaining about it hurting or being bloating or uncomfortable, it's usually the rate is too fast. Then we have bolus. Bolus is a type of intermittent feeding. This is usually, you can see here is a little picture of the baby where we do it by either gravity or a syringe. This, again, bolus and intermittent can only be done in tubes ending in the stomach. We always usually give water this way as bolus. Bolus is usually done quickly, like over 15 minutes or less. A lot of times in the hospital, we use these words interchangeably, and you might hear your patients on bolus feedings, and they're really on what we consider intermittent because they're getting it 4 times a day. But bolus, for our intensive purposes, means you're giving it quickly, over like 15 minutes. Intermittent means you're giving it usually 30 to 90 minutes. Water is always bolused. And we want the intermittent feeding is most often what's used at home. Insurance may not cover a pump. So we need to teach our patient and family how to complete this. It should be completed in the hospital before discharge so we can assess tolerance as well as independence in caring for. So I wouldn't want my patient to be on continuous tube feeding for the last 3 weeks in the hospital. They're discharged home and they're going to go home on intermittent feedings. No nurse has ever been there to assess if the patient can tolerate the rate and this type of feeding. So we'd really want to implement that in the hospital beforehand. Another thing we can try to do is as we transition to food, we may use feedings from 1900 to 0700, or it can be a way to give is like if they're getting less than 50% if they're eating less than 50% of their tray, we may do this as a way to supplement. I used to work in rehab, and we actually preferred the higher rates to be given overnight. So that way the patient could be unhooked from the tube and pulled during therapy. So we would have them on tube feeding from 7 p.m. to 7 a.m. So that way they could do 3 hours or more of therapy without having a tube and a pole get in the way of therapy. You do need a doctor's order for rate for the timing and also fluid boluses. Remember, another thing that's very important to know is that we always start our rate out slow, like 25 cc's an hour, and then we go up to a goal rate. So, for example, you might have an order that says, goal is for, you want to know what type of tube feeding. So it might say like the diet order might say like 1.2 calorie with fiber tube feeding, goal rate 75 cc's an hour with 150 cc's of water, Q 6 hours, bolus. NPO otherwise. So that's telling us they can't have anything to eat or drink by mouth. It's telling us the type of formula we need to get as well as the rate. Now, it's saying the goal is 75 cc's an hour. If this is a brand new order, I'm going to start them out at 25 cc's an hour, and I'm going to increase it by 10 cc's every 4 hours. This is going to be the standard, but again, you're going to want to always follow your site policy and procedure as well as the doctor's order for this. So in that case, if my goal rate is 75 cc's an hour and I'm starting at 25, let me just do the math there. It will take me a minimum of 20 hours to get them to the goal rate. And that means that the patient is always tolerating this, and we'll talk about what that means in just a minute. Here it is. So tolerance. So the best way to assess tolerance is actually not to check residuals, but it's going to be patient complaints. So is your patient complaining of cramping, bloating, or diarrhea? Those are all signs your patient is not tolerating the tube feeding. Diarrhea is defined as more than 4 bowel movements a day or liquid stool that is greater than 200 grams. That's just trying to show, you don't need to know that specific 200 grams. It's just trying to show you that just because your patient has, like, let's say, 5 cc's of diarrhea, 10 times, that necessarily wouldn't be a reason because it's not very much total volume. We only want to stop the tube feeding if the patient complains of discomfort, of those signs and symptoms of discomfort, and or they have a residual greater than 400 milliliters. Again, you need to follow your hospital policy and procedure. So we want to check residuals. When do you check residuals is important to know. So number one, it depends on, that's why again it's important to know what type of tube your patient has. Because if your patient has a tube that is anywhere other than in the gastric, so an NG or a J tube or a PEG tube, you are not checking residuals. So that's what post-pyloric means. If it's not in the stomach, you do not check residuals. Or if you're using a small bore, which a lot of times we use in children, you're not checking residuals because that tube is too small to pull and you can easily clog it. When do you check residuals? Every time before you administer a medication or a feeding, you're going to want to check residual. If your patient's on continuous tube feeding, then you're going to want to check residuals every 4 hours. What it means to check a residual is to look to see how much formula or gastric juice remains in the stomach when you pull back with a syringe. Again, if you pull back less than 400, what you're going to do is you're going to give it back and you're going to continue the tube feeding unless your patient is complaining of cramping, bloating, or diarrhea. You're going to want to recheck it again if it is in this higher range. You're going to want to increase your monitoring. Again, you're going to need to follow your hospital policy. Some say to hold the tube feeding if it's greater than 250, but we're not going to get into those specifics since that's variable. All right, another very important thing to know is what do you need to monitor during treatment? Definitely need to do weight, both baseline and daily, to evaluate the response to therapy. We're going to be looking at their visceral protein status, which would be albumin, prealbumin, and transferrin. We're going to be doing things like TLC, total lymphocyte count, BUN, and creatinine to look at their renal function. We're also going to look at skin at their insertion site. We want to monitor the skin for irritation. If it's surgically inserted in the abdomen, you want to assess for leaking or secretions irritating the skin. If they have a dressing on, you need to move that dressing out of the way so you can actually see. I've had it before where it looked like it was all nice and clean, but I went to go change that dressing and I took the dressing off and it was smelly and green, nasty pus, and I was very lucky that it was time to change that dressing. Otherwise, I might not have caught that otherwise. We'll start the next slide with this.